So, the aim of this session is, by the end of it, is to recognise some of the range of common lower urinary tract symptoms, understand some of the key elements of clinical assessment, and this won't be exhaustive. So I would ask you to go and broaden your knowledge and all our experience by other reading as well. And be wiser about why we need to prevent and detect lower urinary tract symptoms, which are highly important. So, lower urinary tract symptoms are classified into three key areas: storage, voiding, and post-micturition. And usually we elicit these from our patients or carers subjectively, asking them very focused questions through history taking. But we must remember that this particular problem that we're all championing is underreported and underdiagnosed. And less than 40% of people can seek help for their symptoms. So therefore, I strongly believe that if we are the first person on the scene for this patient and or carer, that we should ask those key questions. Are you bothered by a problem with your bladder or your bowel? We do know that there is little education amongst healthcare professionals, can be lack of screening, and low expectations on successful treatment. So that's why we're all gathered today to improve our education and our knowledge. So if we just focus on storage symptoms, we have a whole host of them. There's lots within the storage facility of our bladders, which can be stress urinary incontinence, urge incontinence, mixed features, continuous urinary leakage, the urgency, the increased daytime frequency, waking up at night to void, wetting during our sleep, as in nocturnal enuresis, and of course bladder sensation alterations, either normal, increased, reduced, absent, or not really specific. And then there's the voiding symptoms classification, where we have difficulty emptying our bladders, slow stream, intermittency, so we're stopping or starting our flow, hesitancy, that difficulty getting started, straining to pass our urine, or that terminal dribble. It starts well but just carries on and doesn't really stop very neatly. Finally, the third classification is the feeling that we haven't emptied our bladders properly, and possibly it could be a dribble after we voided. So I think it's really important to know these three classifications, because our symptoms that we ask our patients about will come from one of those or maybe all three. And therefore our skill at asking the right questions in the right way will elicit the best information to help us come up with something like a working diagnosis, something that we can aim to treat. But it goes beyond the physical. So we should seek to understand the patient's perspective. What is it they want to achieve? It may not be our goals, but it's really important that we understand what our patients want to achieve and revisit that goal with that patient during the course of the assessment process and treatment interventions. Recheck what's going on. Are we achieving what these people want to achieve? But of course, we can't do it all alone. We must be working with our therapy colleagues, occupational therapists, physiotherapists, our medical colleagues, and etc. So we got to work in multidisciplinary fashion. So clinical goals must also include the psychological, and therefore the quality of our relationship with our patient is really important. I truly believe that when a patient comes to my consultations and they sit down and we do the welcoming, I just want them to talk to me, to tell me their story. And usually within a couple of minutes they've told me their story, and that listening is so important. And I'll get lots of clues out of that. And that may not correlate with what the doctor has asked me to look into. So it really is important to listen to our patient's story. And that will help us to develop our rapport and have a better working relationship. And hence, treatment outcome is likely or can be more successful. So why is it important to detect and assess lower urinary tract symptoms? Well, we know the evidence stacks up, it's highly prevalent and is expected to increase. When you take this quote from one of the studies, we look at overactive bladder, and it's a global problem. In our country, the UK, is about 17% of the population who has a problem with overactive bladder. But are they treated, all that 17%? No. The impact on the quality of life is pretty significant. And so that's really important when we're listening to our patients' stories to understand the impact on their social life, their work life, and the economic status of that individual as well. And so therefore, it's a burden to individuals, carers, families, and healthcare. And we do know from the evidence that it is saying that incontinence can be a key trigger for people going to a long-term care facility or a nursing home. So it really is important to get it right because it can be the tipping point. And prevalence, in some of the work that I've looked at, the prevalence can reach 45% in Spanish women of stress urinary incontinence and 11% or 12% of overactive bladder. So it is a significant problem. And in my country, we're constantly knocking on doors to say this is a real problem and let's get better work, better education, and making sure we get people to the right place at the right time to be seen by the right people. So when we look at this type of graph, we can see that if we just pitch it against other common health problems that we're working with, incontinence is high up there. It's high up there. So we've really got to champion back in our workplaces how we can raise awareness for all sectors of the health community and social community. So what's the aim of our assessment? We want to establish some type of diagnosis, working diagnosis, from the symptoms we elicit from our patient and or carer. We want to make sure that we exclude those related or unrelated conditions, the urinary tract infection, the constipation. But we also have to assess the level of bother, understand what is it? Is it their bladder or their bowel that's bothering them more, and focus on that. So if people come to me and say, I've got a problem with everything, okay, what are we going to focus on today? What can I help you with today? And implement a treatment plan. And refer on as clinically indicated. We can't do it all ourselves, but we must look out for those red flags, those ones that cause us concern. If we're in doubt, we need to seek advice and support. So what should we be finding out? Well, how often the problem occurs, the severity, the variations between night and day, what can make it better, what sets it off, coping measures and the impacts on symptoms, the quality of life. And there are a host of questionnaires, validated questionnaires recommended by ICS that we can use in our clinical practice and also our research practice as well. And I use that a lot in terms of quality of life, but also symptom severity. It helps to really hone the treatment that we want to do. In terms of referring on, we should have a high suspicion level for things like pain, blood in the urine, recurrent infections, voiding difficulty, significant pelvic organ prolapse, and so on. So what are some of the fundamental elements of an assessment? There are key parts, and you may think of more. But these, I think, are really important for us. The bladder diary, the physical examination, the checking the urine, the making sure the bladder's emptying effectively, medication and medical history. And I'll take each one just a little bit in turn. The bladder diary, I think, is a fundamental key tool for us to use. There are different ways of defining the collection of this data, but I use a bladder diary in my own practice, and I do about 3 days. I ask my patients to do about 3 days. It may not be consecutive days, so if they're working, I'd like a work day as well as a weekend. And it is recommended by ICI, the 4th edition, 2009, to do a 3-day. And in the latest edition, the 5th edition, that's just recently come out, 2013, it is also saying around the 3-day diary. And compliance, we recognise, could be an issue. So it might be that if we have one 24-hour accurate diary, that's worth its weight in gold compared to 3 days that are not completed very well. But I have to say they really do help us to get objective information. When there was a health technology assessment way back in 2006, it showed that the bladder diary was a simple diagnostic method and it was cost-effective and simple. And I asked my GP colleagues out in primary care to do this. And they can actually do a lot of work before they refer on to make sure they can check out what's going on with that bladder. Is it frequent? Is it urgent? Etc. And there's a lot of stuff we can measure from the bladder diary, and you can see all this list of information here. So I won't go through those in turn, but I know you'll have your own experiences of using bladder diaries. And there are many on the market, but I like the one without the times in them. And I understand that there is research underway to develop a validated urinary diary. The physical examination may not be done by you or I in some cases, but we have to be trained in this area and competent. We need to seek valid consent, and it's really important to check the vagina for any signs of prolapse or any signs of lack of estrogen, any skin changes, any dermatitis that influences our understanding of their level of incontinence, rectal examination, abdominal palpation, checking neurology for any change in a neurological status, and BMI. Because we do know increasingly that a raised BMI can lead to increased abdominal pressure and hence the consequence of stress urinary incontinence in some of our women. Urinalysis, we can be simple or complete. The simple is what you and I can do, the dipsticking, or the complete through microbiology. But we must remember it's screening but not diagnostic. It can help us hone our understanding. So we can seek out blood in the urine, glycosuria for checking early diabetes, pyuria, bacteria. But of course, the warning here is that if our patient is over 65 and they are asymptomatic, we don't necessarily want to treat that bacteria. So in terms of the types of sticks we need, we should have one with multi-properties so that we can do a good screening. And we should, it is recommended, perform a urinalysis on every patient who is turning up to our clinics or we're seeing them at home. Post-void residual urine measurement is a very interesting area because it hasn't really reached a consensus on what the minimum or maximum is on this area. But I think it's really important if we are suspicious that our patients are turning up with a neurology in their past medical history, we are concerned they may have altered bladder sensation or they have recurrent UTIs, that we should be checking for a post-void residual urine measurement. And of course, the suggestion is quite clearly that we use the non-invasive approach via bladder scanning. I have a bladder scan and I tend to scan very widely and a lot. Doesn't mean to say you need to do anything clinical about it, but I like to get a baseline. And the post-void residual urine measurement by bladder scan is preferable to catheterization. That still is the gold standard, but of course it is invasive. But I think if we identify a positive post-void residual urine volume, we need to confirm it. So I will always do a second one to confirm the first finding. Medications. Some of the medications that we give our patients, and it is suggested that people over 65 can have at least 3 or more, the polypharmacy, that can lead to symptoms. It can either change urethral resistance or change smooth muscle function. So it really is important that we review medications. Medical history. It really is important to understand and get in some focused questions. One of my patients I was working with had gone through 15 years plus of all different treatments, and no one had asked her, did she have a back injury? And she said, yeah, well, I actually fell and fractured my vertebrae S2 to S4. We know that's a real key neurological spot for innervating our bladder function. So, of course, her problems actually went back to that original neurological injury. We need to define the most troublesome symptom. We may not be able to cover everything in our first consultation, so we need to find out the most troublesome symptom and work with that. And as I mentioned, using the questionnaires will help us to elicit more information and give people the opportunity to share what's actually happening with these symptoms. And there are many available to us, as mentioned, and also in the latest guidelines. What is really important in terms of taking a focused history is just to ask some simple questions. For example, I teach a lot of my colleagues, student nurses, and just to be able to ask, are they bothered by their bladder or bowel, helps. If that positive response is a yes, then we need to move on. Signpost them on for assessment or go a little bit deeper, a bit more focused. For example, during the last week, have you accidentally leaked urine with a physical activity like coughing, sneezing, lifting, or exercising? It is highly likely that they are describing a stress urinary incontinence. Or you could ask, during the last week, have you accidentally leaked urine with a feeling of a strong, sudden need to pass your urine that did not allow you to get to the toilet fast enough? We could have a strong suspicion of an overactive bladder syndrome here. So I think that those focused questions can really help us a lot. But key to this, how do we prevent it? And this is a hard nut to crack for many of us across our countries. Knowledge and awareness is really, really important. The public awareness, but also healthcare professionals. I am still working with healthcare professionals in my locality who actually, it's not an interest of theirs. It just happens, so a pad is used. So it's not something that actually is there's no inquiry. And so we're working constantly of being able to educate our colleagues. We need to link into public health initiatives. It is a public health problem. We need to make sure that we knock on the doors of the public health colleagues as well. At first presentation, whoever that is, and I always stress this with all the colleagues I work with in the National Health Service, whoever you are, you can still inquire. Ask that question, are you bothered? If you can't do anything about it, pass them on, signpost them on. We need to avoid normalization of symptoms. I see many young women who believe it's normal to have that leak after their pregnancy because their friends all have it. So it's something that actually women can live with for such a long time, and then there's a trigger factor that pushes them to get help. But we also must look at reducing risk factors. This is why it links in with public health. We want to reduce high body mass index, screen for diabetes, make sure people are well hydrated, know what to take, what fluids can aggravate bladder. So just fundamental health messages. And we have clinical pathways to help us.
Almost time, Sharon.
Thank you. So we have clinical pathways to help us. This is from the 2009 version. Of the ICI guidance, but this is now the 2013, which I think you've got all in your packs that you might be able to get a little bit cheaper through this organisation. And it's excellent, So these are updated, so these are really helpful for us. But remember, clinical pathways doesn't always equate to good care. So it's about us using them widely and using them effectively and sharing that. Helps our decision making. So we need to raise awareness of the lower urinary tract symptoms. It's dynamic. It's not a static feature. We need to have more frequent inquiries about urinary symptoms by all of us. And you're here, and we're going to go back into your communities to raise the awareness. Symptoms can be assessed by a clinical history, physical exam, and so on. So there's a lot at our disposal that we can do the best for our patients. And because we know there are treatment options that are evidence-based that can help us to seek to resolve those symptoms or improve quality of life. So we should be methodical and extensive enough to provide the basis for managing the patient's symptoms. Thank you very much for listening.